Can you remember this? From squamous,
Yes,
yeah, is metaplasia. Then with prolonged time of smoking, because the smoking, cigarette smoking contain multiple carcinogenic agents, so it causes alteration in the epithelium. So it causes disorder in the maturation, and also differentiation abnormality. So it can cause the change in the size, shape, and organization of the cells. So it leads to from metaplasia to progress to dysplasia. And usually the dysplasia started mild, moderate, and severe. When it becomes severe, you call carcinoma in situ. After that, it causes with the prolongation of smoking. No, I mean if the patient not stop the smoking, it leads to the progression to the cancer, so can invade the underlying tissue. Same thing happen in the reflux esophagitis. With the prolonged reflux, the reflux esophagitis is that because the sphincter in the lower esophagus is not closed, so the acid come from stomach to the esophagus. Usually esophagus is lined by which epithelium is lined by squamous. Okay, but with the time because the irritation of the acid causes the metaplasia. We said why usually have metaplasia because of adaptation, try to adapt. So from squamous to columnar. With the time, if the is not treated, the reflux esophagitis, what happened with the time, irritation can lead to the abnormal in the maturation and differentiation and cause dysplasia. We call Barrett esophagus. If prolonged, the stimulus, it leads to the adenocarcinoma. Same thing in ulcerative colitis, inflammation causes the same thing. Understood? They said other cause is maybe pre-existing hyperplasia or metaplasia. This is what I said. Pre-existing metaplasia either in bronchial or esophagus or colon, okay, because of the stimulus. This is the dysplasia. So characteristic morphology of dysplasia, we said loss of normal orientation, maturation, increased rate of cell multiplication. Cell multiplication is the mitosis. Usually where we can see the mitosis in the basal layer, but in dysplasia we can see in any layer. And also cytological change in nuclear and cytoplasm. Understood. This is the most important in the dysplasia is the normal, loss of normal orientation, maturation, increased multiplication, cytological changes in nucleus and cytoplasm. What is the cytological changes? Like
increased
what?
nuclear to cytoplasm ratio.
Yes, very good.
Pleomorphism.
Very good. Tell.
Hyperchromatism.
Yes, very good. Irregular nuclei, isn't it? Irregular shape. So we said increased size, hyperchromatism, coarse chromatin, irregular nuclear membrane, increased nuclear cytoplasmic ratio, and polymorphism. Okay. It's important to know this term because sometimes when we are in the systemic block, if you don't know the polymorphism, it's difficult. You have to, remember these features of malignancy, because I am not going to repeat again in the systemic block. Okay. So as we see here, this is the normal maturation of the epithelium, the basal layer. Can you see? There is a difference from basal layer to the outermost layer, isn't it? But in dysplasia, if you look at the basal and the outer layer is the same. They are loss of maturation. When we said the difference between basal layer and the outer layer, this is what we call maturation. See, look at the basal layer is they are small, closely packed cells, hyperchromatic, isn't it? Densely, few cytoplasms and darkly stained nuclei. When we go up, the cells become bigger and polyhedral, then become flattened. This is what we call the normal maturation. Okay, but in dysplasia, this maturation is lost. So disorder in the maturation and differentiation of the cells. See, in the normal epithelium, we can see there is a differentiation, isn't it, between the basal and the outer. But in the dysplasia, no differentiation between the cells. So abnormality in the maturation and differentiation of the epithelium. Okay, so and other features, cytological changes, high in C ratio, increased multiplication, irregular nuclei, hyperchromatis. So this is the features of the dysplasia. We said mild, moderate, and severe. Mild when the 1/3 of the epithelium is involved. 2/3 is which is mild dysplasia. The pole thickness is the carcinoma in situ or the severe dysplasia. Okay. So what is the significance of dysplasia? It is pre-malignant lesion, usually associated with risk of cancer. So what is the cancer? Is malignant neoplasm. Risk of cancer develop depend on the grade, duration, and site of dysplasia. If we see dysplasia is a disorder, we said, of the growth and maturation, and it is precancerous lesion, morphological change. There is similarity and difference from the cancer. The similarity between the cancer and dysplasia is the morphological change, right? Isn't it? So what is the neoplasia? We said new growth, which is excessive, persistent, uncontrolled growth of new tissue to produce a tumor. When we said neoplasia, means our neoplasm means benign and malignant. Is not indicate malignant, both of them. You can see here in this one the intact epithelium. So dysplasia only we said disorder in the epithelium, no mass, and also the basement membrane is intact. The underlying tissue is not invaded. Okay, benign tumor is forming of the mass, but no invasion. It's just by compression of the surrounding tissue. Okay, malignant is actually disorder of the epithelium. Okay, and maturation and morphological change, and also invading the underlying tissue, and they forming also mass. So what is the difference between the malignant and the dysplasia?
Mass.
Invasion of the basement.
Yeah.
Invasion.
Yeah, invasion. In dysplasia, no invasion, isn't it? Hello. No invasion in the dysplasia, but in cancer they are invade the underlying tissue. Also in dysplasia, no mass, but in the malignant they forming mass. So what is the similarity between dysplasia and the cancer?
Disorder
Yeah,
of the
normal growth.
epithelium.
The morphological change is high in C ratio. I mean the morphology, CIN ratio, hyperchromatis, multiplication, regularity, loss of maturation. This is the, the similarity between both of them. Okay, understood? Okay, said dysplasia is confined to the basement membrane, so complete removal is curative. Severe dysplasia, carcinoma in situ, no mass. Okay. Cancer are invasive, break through the basement membrane and infiltrate the underlying stroma. Also spread through the blood, lymphatic, and they forming mass. Okay. In dysplasia, no metastasis, no spread to the blood and lymphatic. But in cancer, they can metastasize, they forming mass, they invading the underlying tissue. Okay. Dysplasia, the mild and moderate are reversible. Okay, but malignant is irreversible. Okay. So the similarity, we said increased high insertion, nuclear polymorphism, lack of differentiation, and increased mitosis. Okay. I need you, if you have to remember those, I mean the terminology. What is neoplasia? We said process of new growth. Neoplasm is abnormal mass of tissue with autonomous growth and exceed that of normal tissue, may be benign or malignant. Cancer is the malignant. When we say cancer, indicate the malignant tumor. Okay. Carcinogenesis is the serious process or event leading to full malignant potential. Carcinogen, when we say carcinogen, is a substance that can cause neoplasia. Okay. So what is the predisposing to the cancer? We said genetic, geographical, environmental, like they said NPC. NPC is nasopharyngeal carcinoma. They found more in Chinese. Stomach and colon cancer is more in Japanese. Maybe they said because of the environmental, maybe due to lifestyle, some certain foods affect on the leading to this cancer. The exact cause is not known, but they relate to the geographical, because some of these migrants they migrate to the California. Remember, the stomach cancer will be decreased, and the other cancer like prostatic cancer is increased. So they relate the geographical or environmental factors for the development of the cancer. Also age, most of the cancer is increased in the old age. Okay, like certain tumor is related to the child, or certain tumor is related to the old age, like neuroblastoma, Wilms tumor, nephroblastoma, neuroblastoma. Retinoblastoma is more, Ewing sarcoma is more susceptible to the childhood more than in the adult. Okay. Also hereditary, like breast carcinoma and colon cancer, retinoblastoma, hereditary. Remember the breast CA, which type of the gene mutation in breast? Hello? Which type of gene is in breast CA?
Is it your BRCA gene?
BRCA1 and BRCA2, which is BRCA1, BRCA2. Okay. In colon cancer?
APC.
Yeah, APC gene, this one, adenomatous polyposis coli. Those BRCA1 and BRCA2 and APC gene is what type of gene?
Tumor suppressor gene.
Yeah, tumor suppressor gene. Also, retinoblastoma is familial, okay, due to the hereditary mutation of the retinoblastoma gene. Retinoblastoma is also considered tumor suppressor gene. This is there are category autosomal dominant inherited cancer syndrome, defective DNA repair gene syndrome. This occur in the skin cancer, familial cancer like APC gene, familial adenomatous polyposis coli. Other predisposing, we said acquired, like liver cirrhosis, Okay, can lead to hepatocellular carcinoma. Chronic ulcerative colitis can cause to the colon cancer. Leukoplakia of genital mucosa causes squamous cell carcinoma. If you remember the 4 genes, very important theory of carcinogen, the growth promoting proto-oncogene, inhibiting tumor suppressor gene, regulate apoptosis, gene that regulate apoptosis, and DNA repair gene. This is the 4 genes that regulate the cell cycle and the cell proliferation. Okay. So if you remember this, you still remember this, the steps, multi-steps carcinogenesis. We said if the cells is exposed to the environmental agent like chemical, radiation, virus, this agent may cause defect in the DNA, so the DNA damage. In this case, the gene, which is DNA repair gene, is their job is to repair the DNA, and the cells, the cell will be returned to the normal. But if this gene have some mutation or defective anything, this leading to what? So the DNA will be, the cells will be divided with the mutation in the DNA. Okay. So the mutation in the genome in the somatic cells will be, the cells will be divided into many cells have the same defective in the DNA. Okay. In this case, we have these genes that regulate. Suppose the cells will be proliferate, right? So activation of the growth promoting oncogene. If this gene is okay, so what happens is prevent these cells to survive. Prevent the growth. But if there is mutation in this gene, we call oncogene. Oncogene is the mutation of proto-oncogene. So it will allow the cell to survive and grow. Okay. So in tumor suppressor gene, it's supposed to be this to suppress these mutated cells, right? But if there is inactivation of tumor suppressor gene, so these cells will be, grow, and nothing to stop these cells. Also, the apoptotic gene, if detect any mutated cells, it immediately, increase programmed cell death. But if there is defect in this apoptotic gene, what happens? So these cells, the mutated cells, will be unregulated. Okay, it will be proliferate. Nothing stop these cells. So what happens? The cells will be survive and causes clonal expansion. Clonal expansion means it will be divide more and more. For these cells to be survive, it need to the angiogenesis. It need nutrition, need blood, so they forming the angiogenesis. And also they escape from immunity also. This is very important, Now they try to treat that cancer by increase the immunity of the people. Okay. So with additional mutation, so the tumor will progress and forming malignant neoplasm and invasion and metastasis. Understood these steps? Hello?
Yes, hello.
Yeah. I mean, if you know these steps, it is easy to understand how the cancer be happen. So just the activation of proto-oncogene, we have point mutation. Most of the cancer in the body have the RAS and KRAS. Chromosomal translocation, we said our example is Burkitt lymphoma, which is translocation from 8 to 14. Chronic myelogenous leukemia is also translocation part from 9 to 22. So they forming APL gene or 2 PCR locus, and this is we call oncogene. So it leading to the chronic leukemia. Gene amplification, another type of proto-oncogene activation. So the doubling, doubling of the code of the gene. So from 3 to 300 copies. So in this case, in case of neuroblastoma tumor. For tumor suppressor gene, usually inactivation. You cannot see activation of the tumor suppressor, no, inactivation. So the tumor suppressor gene become inactive. Okay. Prevention, usually it is suppress, we said suppress the cell or control the cell, growth, the suppressor gene. And proto-oncogene or oncogene causes what? Cell survive. If we have oncogene, is called the gene that cause cell growth and survive. But in suppressor gene is control the cell pathway or cell cycle. Okay, so we have like retinoblastoma, in familial retinoblastoma, APC gene in familial adenomatous polyposis coli. We have a case in the practical, right? The APC gene. If you see the patient is younger age, about 17, 20 years, and he has multiple polyp in the colon, and also has familial history of cancer or something, we think about APC gene mutation. Okay. Gene that regulate apoptosis, we have example BCL2. The overexpression of BCL2, it leads to the cells to be survived, no death for the malignant cells. So this in case of B-cell lymphoma. Okay. The other carcinogen like chemical, radiation, and virus. So we have in the virus, we have human papilloma virus, causes squamous cell carcinoma. The Epstein-Barr virus can cause the Burkitt lymphoma, nasopharyngeal carcinoma. Hepatitis B virus causes liver carcinoma. Okay. This is most of the carcinogen. Okay. I mean the dysplasia and carcinogen. This is the important topics in that. So for the neoplasia one, important is to know the difference between the benign and malignant. If you still remember differentiation and anaplasia, we said the benign tumor is well differentiated. Structure may be typical of tissue of origin, same, but they forming only the mass that compressing the surrounding. Malignant, we said some lack of differentiated with anaplasia structure is often atypical. Like we said, for differentiation and anaplasia, some of them they well differentiated and some of them they are poorly differentiated, right? Rate of growth, usually benign is usually progressive and slow growing. Maybe stand still or regress. Mitotic figure are rare and normal. But in malignant is rapid growth. Mitotic figure may be numerous and abnormal. Okay, for invasion, usually The benign tumor, they are cohesive and expansile, well-demarcated mass. Isn't it? Doesn't invade or infiltrate the surrounding tissue. But malignant, they locally invasive, infiltrate the surrounding normal tissue, sometimes means cohesive and expansive. Metastasis absent in benign tumor, but malignant, they metastasize to the other organs. Understood the difference? Differentiation, rate of growth, local invasion, metastasis. Okay, this is the main difference between the benign and malignant. Understood?
Yes, doctor.
Any question here? No question. Okay, like here, squamous cell carcinoma, if you can see, this is well differentiated. Why we said well differentiated? Because this keratin pearl, they forming keratin pearl, because the normal squamous cells, they secrete keratin. Okay, so we said high nest of malignant cells. This is nest of malignant cells invading the underlying tissue, and they are surrounded by inflammatory cells. Can you see these inflammatory cells? And they are forming the keratin pearl. See, look at here, well differentiated. Why we say intercellular bridge. The normal squamous cells, they have this kind of intercellular bridge. Okay. See, look at adenocarcinoma. This is well differentiated. Why we said well differentiated? Because we can see the malignant gland. See, we can still see the malignant gland. But in poorly differentiated, you cannot see the gland. Okay. Poorly differentiated, you can see only the signet rings. Okay. Signet rings, they contain mucin. Lipoma. Look at the well differentiated one, is look like the fat cells. They resemble. This is well differentiated. This is lipoma, is the benign tumor. Okay, don't mix is liposarcoma. Look at the liposarcoma, is the pelomorphic cells. See, and they are lobulated and the malignant nuclei there. Okay, we call lipoblast. What's this? This is what? Oh, see, remember this? Do you still remember this? Is it clear? Can you see? The stratified squamous epithelium, what is the benign? Do you still remember? Benign tumor of stratified squamous epithelium is what?
Yes, squamous cell papilloma.
Yes, very good. Yes, squamous cell papilloma, the malignant?
Papillocarcinoma.
No, squamous cell carcinoma. Okay, basal cell of skin, basal cell carcinoma, no benign from basal cell of skin. Okay, epithelial lining of gland or duct, the benign one is what?
Adenoma.
Very good. Malignant?
Adenocarcinoma.
Yes, adenocarcinoma. Neuroectoderm?
Neuroblastoma.
Nevus.
Nevus.
Malignant?
Malignant melanoma.
Malignant, yeah, very good. Liver cell? The benign?
Liver cell adenoma.
Yep. Malignant?
Hepatocellular carcinoma.
Yeah, very good. Urothelium?
Transitional cell papilloma.
Yeah, very good. Malignant?
Transitional cell carcinoma.
Yeah. Transitional cell carcinoma, yes. Placental epithelium.
Leiomyoma.
Placenta.
Neohydatiform.
Yeah, very good. Malignant.
Choriocarcinoma.
Yeah, very good. Germ cell tumor. No, benign, just seminoma and embryonal carcinoma. Okay, so I mean, you have to remember that not all have OMA is benign. Also, see, we have seminoma, but malignant. Okay, what else have OMA is malignant?
Melanoma.
Yeah, melanoma, very good. What else? Lymphoma. Okay, because in the exam, maybe I can give you like a single best. Okay, I can put all have OMA, but I mean there is a difference. You have to know which one is a benign, which one is malignant, so you can answer the question. Okay. Also, you have to know the connective tissue, the sarcoma, all the sarcomas. Okay. Pathway of spread. We have direct spread, which we local invasion, or transcolonic spread, or lymphatic spread, or hematogenous spread. Transcolonic, like when we say direct spread or local invasion, when there is, for example, duct, and they invading the surrounding tissue, or for example epidermis, if there is tumor in the epidermis and they invading the dermis, so we call this local invasion. Okay. Or if there is breast tumor, they invading the muscle of the chest, we call this local invasion. Transcolonic spread, when there is for example, if there is ovarian tumor, they invade the capsule of the ovary and they spread through the peritoneal cavity. Sometimes you can see tumor seeds in the peritoneum. From this can be spread to the colon, can be spread through the liver. This we call transcolonic spread. Lymphatic, when there is a tumor directly to the lymphatic tissue, like if in case of breast CA, they can spread to the axillary lymph node. Okay. Hematogenous spread, when there is like tumor in the lung and the tumor is spread to the bone, is by hematogenous spread. Okay, understood? You can see here, this is the pathway of spread. We said local invasion, the tumor extend into the lung tissue if there is tumor there. If transcolonic, see through the pleura or the cavity. Okay. If through the hematogenous is through by blood. It can be spread, to the brain, to the bone, to any area. And also sometimes the tumor is spread through the lymphatic spread. Okay, so different pathway. I mean, not certain tumor only have a certain, spread. They said most of the sarcoma, they like to spread by hematogenous spread. Okay. So transport of the lymphatic spread, transport of the tumor to the regional lymph node, ultimately to the other part, common in carcinoma, like breast CA, to the axillary lymph node. Hematogenous spread typically of sarcoma, either through the vein or arteries. Okay, spread to the lung, liver, and to other systemic. Okay, mechanism of invasion and metastasis. This is very important to know. Okay, we said here first the clonal expansion, growth, and angiogenesis, then metastatic subclonal. So adhesion, first they have form adhesion, invasion to the basement membrane, we said, to the underlying tissue. Okay, and then they have to dissolve the extracellular matrix. Okay, and also the basement membrane to go to the blood. Then when they go to the blood, they clump together, they form like what we call clot, or emboli. So to travel through the blood, they have to escape from the immunity. Okay, so they have to escape from the especially from the lymphocyte. The immunity is the lymphocyte. They forming, they covered with fibrin platelets to form to escape from the immunity. Then they travel. Once they reach to the target organ, they do the same things, dissolve the basement membrane and the matrix, and then go to the target organ, and they form the clonal expansion, angiogenesis, and growth. Understood? This is in summary. Dissolve basement membrane, matrix, enter blood vessels, tumor emboli, escape lymphocyte, dissolve matrix again, enter tissue, and angiogenesis. Understood? Hello?
Yes.
Okay. I think I covered most of the neoplasia also one. And the carcinogenesis, the things, neoplasia 2, the important things to know the clinical effect of neoplasm. We said local is the like compression, obstruction, infection, ulceration, and infarction. We said compression, the tumor, sometimes they are benign tumor, but they can cause the serious or dangerous effect, like in myxoma of the heart can cause arrhythmia. Also, if there is meningioma, can compress. Even meningioma, they are benign tumor in the brain, but they can compress the vital organs, the vital centers in the brain, and causes cardiorespiratory distress. Okay. Obstruction also, maybe the tumor can obstruct the abdomen, causes mechanical obstruction and constipation, and causes abdominal obstruction. Infection. Also, the tumor can be inflamed, and ulceration. Ulceration can cause the bleeding. Sometimes the center of the tumor is necrosed and ulcerated, so it can cause bleeding. So sometimes the patient presented as adenocarcinoma of the colon by melena. We said melena is the blood in the stool. So this is due to ulceration. Okay, even infarction, the tumor can be infarcted, less blood supply. Okay, and also can causes infarction of certain organs. Okay. Second effect is hormonal effect, like pituitary adenoma. Remember, we're in the endocrine. The effect of pituitary adenoma can release what? Pituitary adenoma. Hello.
Prolactin.
Secretion hormone.
Yeah, hormones like growth hormone, ACTH hormone can release prolactin, a lot of hormones. Okay, this is we call hormonal effect. Okay, when there is tumor in the endocrine gland. Also, parathyroid can release parathyroid hormone. thyroid carcinoma is not causing the release of the thyroid hormone, but parathyroid hormone can release parathyroid hormone. Okay. Cancer cachexia, the third effect, which is general systemic effect, fever, paraneoplastic syndrome. Okay, what is the cachexia? Cachexia, we said, wasting syndrome, characterized by progressive loss of body fat, lean body mass, accompanied by profound weakness, anorexia, and anemia. So, what is the cause, exact cause? They said is not nutritional demand of the tumor. I noticed many of students, they have wrong concept that the tumor when grow is need more nutrition. It's not that actually. Sometimes a small tumor can cause also cachexia. Okay, actually is due to action of soluble factor we call cytokines produced by tumor and host in response to the tumor, and also the tumor necrosis factor and interleukin produced by macrophage and some other soluble factor produced by tumor like proteolysis induced factor, which increase the catabolism of the muscle and adipose tissue. So why the patient is become very thin? We call wasting syndrome because of catabolism of muscle and adipose tissue. Okay. Okay. Paraneoplastic syndrome. Paraneoplastic syndrome. We said symptom complex in cancer-bearing patient that cannot be readily explained by either local or distant spread of tumor or by elaboration of hormone endogenous to the tissue from which the tumor arises. We said, remember the local effect we said is due to the tumor in the pituitary adenoma or parathyroid, right? But paraneoplastic syndrome actually is not due to the presence of tumor in the endogenous tissue, in the endocrine, for example, or not due to the metastasis, because if there is a tumor metastasized to the, for example, to the adrenal, it causes release of cortisol hormone, right? But in paraneoplastic syndrome, actually, if we look at the glands, they are normal, but because of what? Because of ectopic tissue releasing this kind of hormone, like what? Like, for example, endocrinopathies, we have like in Cushing syndrome, actually, patients have Cushing syndrome, the same, they have ACTH hormone and the same features of Cushing syndrome. But if we scan the pituitary and the adrenal gland, they are normal, no metastasis, no tumor. But what is the problem? Where is the tumor? Actually, the tumor is where? What do you think, where? Where?
Lung.
Yeah, in the lungs. So the tumor small cell lung carcinoma can release the ACTH-like hormone. Okay. So this is what we call paraneoplastic syndrome. Also, they said also hypoglycemia is due to elaboration of insulin or insulin-like substance from fibrosarcoma. If you scan Langerhans in the pancreas is normal, but the problem here is fibrosarcoma releasing the insulin. Okay. Also, they said mesothelioma and hepatocellular carcinoma. Okay. Also, hypercalcemia. I mean, the most common is the Cushing syndrome and the hypercalcemia. Hypercalcemia also is stenosis induced by cancer, which is not, if usually the hypercalcemia is either due to disorder in parathyroid, right, or maybe due to tumor invading the bone, can cause osteolysis. If we say osteolysis is not paraneoplastic syndrome actually. If we see parathyroid hormone disorder is not also paraneoplastic syndrome. Usually bone is normal and also parathyroid normal, But what happened is the production of parathyroid hormone is due to the other tumor. Like what? Which tumor can release this parathormone like receptor, like peptide, is the carcinoma of breast. If we scan, you know, the paraneoplastic syndrome is not easy to diagnose because we have to do many investigation for the bone, for the endocrine. So they found the breast CA and lung squamous cell carcinoma. They release the parathyroid like peptide related protein and also from kidney, so it causes hypercalcemia. Understood the paraneoplastic syndrome? فهم? Also they said they found also neuropathies. Sometimes, you know, I saw the one case, they have peripheral neuropathy and they don't know what's the cause. They have done they did in the hospital they did for him a lot of investigation of the brain, for the nerve conduction, for everything, but they didn't find any cause. Okay, even even they do the lung also scan. They said maybe he has cancer or something. And the final diagnosis they do is maybe paraneoplastic syndrome due to autoantibody causes neuropathy. But where is the tumor? They didn't find actually. But usually most of the paraneoplastic, usually you can see occult tumor in anywhere. We have to do scan the whole body to find where is the tumor. Okay. So the common one is we said Cushing syndrome is due to ACTH, is coming from lung carcinoma, hypercalcemia, parathormone-like substance from lung, hyponatremia, ADH from lung carcinoma, polycythemia, erythropoietin, Krauser syndrome, hypercoagulability, hypoglycemia, insulin, carcinoid syndrome. Okay, any question here? The thing, the grading, staging for malignant tumor, we said what is the the important differentiation anaplasia measure how the tumor resembles their origin is the grading. When we said rate of growth, local invasion, metastasis, and measure extent of the tumor spread is what? Is a staging. Okay? Faham? So what is the grading system? Based on the tumor differentiation, we said we have well differentiated or grade 1, okay, which is the retain the functioning characteristic of normal counterpart, like glandular neoplasm. If they still maintain the mucin, papillary structure, cribriform, acinar, this we call well differentiated adenocarcinoma. Okay, grade 2 or moderately differentiating, when you see half of the tumor, in well differentiated, the majority you can see glands or papillary, or in in moderate differentiated or grade 2, you can see 50-50. In poorly differentiated, you can see about 25% they have glandular structure. Also, same thing, squamous cell carcinoma, they forming keratin. Yeah, if you remember the previous picture. And also they have desmosome or intercellular bridge. In poorly differentiated, you cannot see only occasional keratin. Okay. For endocrine neoplasm, they produce the hormones. Okay. So the differentiation, when we said well differentiated, is we said correlate with tumor aggressive. For poorly differentiated adenocarcinoma or any cancer is more aggressive. In well differentiated is less aggressive. Okay. So if you see here well differentiated squamous cell carcinoma, they have the keratin pearl. This is nest of tumor. They have keratin pearl and also the intercellular bridge. Okay, in well differentiated or grade 1 the adenocarcinoma, you can see this the glandular structure gland, but here there is no gland, only cells have the mucin signet ring. For staging of malignant tumor, indicate the anatomical extent of tumor may be performed at surgery, because how we know the extension of tumor, where is it, or by radiological assessment or by biopsy. Okay, so how we know the staging? We said in grading we assess by histopath, by biopsy, because we can know the features of tumor, whether it is well differentiated or moderately or poorly differentiated. But staging is by staging assessed by radiology. How? Because we have to do scan for the body, whether the tumor is metastasized to the liver or metastasized to the, or there is no metastasis. Okay, at surgery we can know the stage, whether it is stage 1 or 2 or 3, by size, by you see the lymph node, or it is invading the capsule, or like that. Okay, so how the most important, I mean, staging is T&M staging, used in most of the tumor. We use the T&M staging. T is the tumor, N is the node, and M is metastasis. Okay, is we said primary lesion when the Tx cannot be assessed. T0 in situ from T1 to T4 is increasing the size. Okay, original lymph node, N0 no nodal, in 1, 2, 3 increase the number of nodes involved. Metastasis is M0 no metastasis, M1 is a blood bone. Okay. So the common, there is other staging system like AG, American Joint Committee, FIOG of gynecology, Dukes. Dukes is in colorectal carcinoma. Clark staging is for melanoma. Okay, if you see here Dukes staging, we have astral color stage and we have Dukes. Okay, astral color is used here to see the stage A, stage B1, stage C1 and D. Okay, in Dukes we only have A, B, C. Okay, for A and B1 is considered in Dukes as A. B2 is considered, B2 in astral color, okay, is considered in Dukes is B. C1 and C2 in astral color is in Dukes, is Dukes stage C. Okay, if you look at here, A, Dukes A is the tumor still within the mucosa. Okay, stage B1 is already invading muscularis mucosa, or is reached to the muscularis propria. So B2 is invading the muscularis propria. Okay, B2. C1 is the important thing, is the any stage of this B1, but no with nodal metastasis. Okay. D is metastasis to the other organs. Okay. Okay, understood.
Yes, sir.
For prognostic factor, what is the prognostic factor? Is tumor stage, tumor type, tumor grade, vascular invasion, and nodal involvement by tumor. A prognostic factor is important to know how much the patient survival. Okay, so when we said stage 1 is different from stage 4, because stage 1 means the patient can survive more than those of stage 4. Stage 4 usually is patient have after the chemotherapy no surgery because it is already stage 4 is involved the other organs. Okay, but in stage 1 still conified, they can, you know, they can treat the patient very well. Also tumor type grade, when we said well differentiated tumor is good prognosis than that of poorly differentiated or grade 3. Vascular invasion, when the tumor is not invade the vessels, is good prognosis because there is no chance for metastasis. But if there is vascular invasion, there is the chance of metastasis is more. Okay. Also nodal involvement. If the node is involved, that means that the tumor is have a chance for metastasis more than those of not nodal involvement. Okay. Other prognostic factor like age, sex, receptor expression in the breast, we have the estrogen, progesterone receptor. If they are expressed, it's better than those not expressed because patient we can treat with the hormonal treatment. Oncogene expression, if there is oncogene expression, means bad prognosis. Tumor angiogenesis, also DNA ploid proliferative index, if is high, indicate the aggressiveness of the tumor and poor prognosis. Okay. For tumor marker, what is tumor marker? Tumor marker is a molecule that can be detected in plasma or other body. Is include either surface antigen or cytoplasmic protein or hormone or enzyme or biochemical indicator of presence of tumor. Okay. Is cannot be constructed by primary modality of diagnosis. I mean, if the tumor marker is increased, is not indicate or diagnostic for the tumor. No, it's support. See, this is the important. It support the diagnosis. For example, if you have colon cancer and the CEA increase, this support our diagnosis that is colon cancer or adenocarcinoma of colon. Also determine response of therapy because after surgery and chemotherapy, if the CEA is decreased, that means the tumor is response to our therapy. Also indicate relapse during follow-up, means after 6 months or 1 year. If the patient usually after surgery and chemotherapy, usually they can for follow up. If the CEA is increased after usually after treatment is decreased, isn't it? The level is decreased. But if there is increase, that means there is relapse. That means the tumor is returned back. So we said the important or the significance of the tumor marker is support the diagnosis, determine response of therapy, indicate relapse during follow-up. Understood?
Yes, doctor.
Yeah, with our example like CEA, we said 60 to 90% is positive in colorectal carcinoma, 50 to 80% pancreatic, 25 to 50 is in gastric and breast CM. Also in alcohol can be ulcerative. Why we said we cannot diagnose with this year because it is not specific. It can be increased in other conditions. But if we have tumor in the colon, we said this is maybe colon cancer because CA is increased. Okay, it supports our diagnosis. Also, we said lack specificity, sensitivity required for early detection of cancer. Prognosis, preoperative level correlate with tumor burden. Level is with Duke's staging if very high. CA indicate the tumor, the Duke's stage is advanced. Okay. In CA positive colon cancer, presence of CA level is 6 after therapy indicate residual disease. Also recurrence indicate by rising ACA level often preceding clinically detected disease. As we said the most important or significance of CA is supportive of treatment of the diagnosis. Also indicate the response to the therapy and also indicate relapse during follow-up. Understood?
Yes, sir.
Okay, other tumor marker, we have alpha-fetoprotein in hepatocellular carcinoma, also germ cell tumor and hepatitis cirrhosis. PSA for prostatic CA, HCG for the seminoma and trophoblastic tumor, CA125 for ovarian and chromogranin indicating. But the most common or important to know for this level is CA and alpha-fetoprotein. Okay, I think that's all. In neoplasia 2, any question? Hello?
I think no, Doctor.
I think this is the important things you need to know in the dysplasia, carcinogenesis, neoplasia 1 and 2.
All right, Doctor.
Do you have any question? Do you have any question?
I think no, Doctor.
The exam will be SBA. Single best is 65 question because include the mid course and end of course. It's AQ 3 and also VIQ is 7 question. So
How long is it, Doctor?
how long is what? Which 3 hours?
3 hours. So we take the mid course and of course at the same time.
Yes,
Just
yes.
increase the question.
Yeah, increase the question to 65 it will be. So each question 2 minutes. Okay. And it's AQ, each question 15 minutes, so 45 minutes, the 3 is AQ. VIQ 2 minutes each question. Okay. It's AQ, of course, is the question usually not one, I mean, from one topic is like a case can be involved 3 or 4 topics. For example, if
Doctor, I have a question about the DIQ.
Yes. Yes, what's your question?
Doctor, for the VIQ, is it going to be like pictures and then we pick SBAQ or?
I think is to write the description.
Doctor, I have a question about the VIQ part. how will it be done? I mean, will there be a picture from the lab, not lab,
Yes.
the simulation
No.
we did, and do we just have to label it, or?
We have, the same, I will give you the same picture that we have in lab, isn't it? We have 7 lab, right? I can give you
Yes.
either gross or slide, okay? And then I ask you to either describe the microscopic features, or can I ask you label certain areas to give the name of these, for example, and also the diagnosis. Diagnosis is what is the condition, for example, is it liquefactive necrosis or like that, or coagulative necrosis or like that, or infarction, or what's that? Same things that we have it in our practical. Or
So,
gross.
Doctor, the SAQ,
Or gross also.
the SAQ doesn't come from.
It's a AQ. I said should be question. Either maybe question include the 3, the neoplasia, carcinogenesis, and neoplasia 2. Maybe one question, and one question from the beginning either. I mean, include inflammation, necrosis, all this, and also one question, of course, from Prof. Nani, topics like that. So we need to cover.
Sorry, Doctor, I didn't get the last thing you said.
Which last things? I said.
You said the last question. One question maybe from.
One question maybe from. I said the actually. We have the three things, isn't it? At the beginning is the inflammation, necrosis, right?
Yes.
Maybe one question include all these topics, is not certain topics. I mean, the third question maybe from all the malignant neoplasia 2 is usually scenario, but I include the question from the 3 topics, for example, and one question from Prof. Nani parts also.
I see. Thank you, Doctor.
So this is kind of, and I usually, and the SAQ is not that, I mean, difficult, or is maybe I can take the scenario from the practical, and I include some theory inside. Okay.
Understood. Thank you, Doctor.
Doctor, I have a question. In your multi-step theory of carcinogenesis, there's a component after clonal expression for escape from immunity. How does the cell does that?
Yeah, they coding. They forming a code and escape from the immunity. They cannot. I mean, the immunity cannot identify. If they identify that there is a foreign body, they, by certain receptor similar to the immunity, like that. So the immunity cannot identify it is a foreign body. This is the main things, the cancer can survive. Now they said the new medication is how to improve the immunity and lead the immunity to identify the for the tumor, that is tumor. This is the important steps, because mutation is sometimes difficult to treat. Is the escape of immunity. If the immunity is quite good, it can kill the tumor. So they said the new medication is to how to improve the immunity. Because you know the chemotherapy is kill the tumor as well as the normal cells. So have a lot of side effect the chemotherapy.
All right, thank you.
Okay.
So doctor, the VIQ, the SBAQ, and the SCQ will all be in one paper.
Yeah, maybe we can. I can give you first the SBAQ. After you finish, submit. Then after that, the SAQ. Then submit. Then VIQ. Like that. Okay. We don't know is still the MCO extended or not.
No.
Not sure yet.
Was it?
But for the university, it's until December, I think.
That means you will get the exam online, isn't it?
Yeah, for the left of the block. Until December.
So how is the Zoom? I heard you use the Zoom and
Yeah,
Microsoft together.
I think it's okay.
But I mean, 125 can be seen through the Zoom.
Yeah. You need to scroll lah.
Okay, all the best. Please study. If there are any question, you can text me. Okay.
All right, thank you very much, Doctor.
Do you have any question in other parts? Hmm? You know,
No, doctor.
for SBAQ, you may not get the same. I mean, the answer in our PowerPoint is need to understand what what's that. You understand the concept. What is the necrosis, for example? What is not the same option you can find in the slide. Understood? Okay. There is no question, so we can end our class.
Yeah, I think so.
Okay. Okay. Thank you and goodbye.
Thank you, Doctor.
Thank you, Doctor.
Thank you very much, Doctor.
I hope this revision is okay
Thank
for
you,
you. This revision okay for you?
Yes, doctor.
Yes.
It was very compressed, but it's very short and sweet.
Sorry?
It's compressed and but it's very it goes well.
I mean, this is the important things you need to concentrate.
Okay.
Okay.
It's easy to digest.
Okay.
Right?
Okay, all the best. And goodbye.
Bye.
Bye.
Thank you, Doctor.
Thank you, Doctor.